Good afternoon, everyone. Thank you, IMN APR, for giving me such opportunity to talk on the age-old entity pleural effusion. So, moving from lung parenchyma to airway to embolism and transplant, and now we are moving towards the pleura. My today's topic of discussion is diagnostic and therapeutic approach to the patient of exudative pleural effusion. Definitely, it's not a classroom talk. We'll more talk about the clinical aspect, how to go with the confusing reports when the reports are borderline, when the reports are negative, how to intervene with the patient. And so let's navigate through this gray zone of pleural effusion in the era of the advanced diagnostic. After that, most of the here we have deal with the pleural effusion in the OPD and the IPD centers. So pleural effusion is the most common consult in the clinical practice. The common clinical dilemma we face in the day-to-day OPDs are whether the fluid is of TB versus malignancy, why the patient need the repeated pleural fluid tapping, what the borderline or confusing reports actually mean. So in this era of precision, our goal should be to minimize the empirical treatment and to maximize the definitive diagnosis. So the first question in the pleural effusion is whether should do I need to tap this patient? So the answer is almost always yes. If symptomatic patient, unilateral undiagnosed effusion, yes, you do tap at least for the diagnostic purpose. There are few red flag signs in the pleural effusion patient where you should consider tapping. If patient is having fever, pleuritic chest pain, shortness of breath, coughing, weight loss, as your CT suggests, you have the loculation, septation, pleural irregularity, pleural nodularity. So there is only one exception where we should not tap, or we should just carefully monitor the patient in the asymptomatic patient having minimal or non-tappable effusion where the risk of pneumothorax is very high. In only this scenario, we'll just keep the patient under very close eye. So let's move. What is the role of radiology in the pleural effusion management? Chest X-ray is a very basic tool. Most of the patient will come with the chest X-ray. It's very basic tool. Now we should always do the ultrasonography of the chest in the pleural effusion patient. It will help to diagnose the amount of pleural effusion. It will guide us in the procedural safety. It will say about the loculation, septation. So even before tapping the patient, you can predict whether this patient will need the fibrinolysis, whether this patient will end up with the surgery if there is any loculation or septation. So remember, do USG before every tapping and do not blindly tap. Okay. So you can see the first image in the upper part, that image showing ultrasonography image of the chest showing the loculated septated pleural effusion. So another CT chest is an investigation tool in the pleural effusion management. It can help to guide in the pleural thickening or nodularity, which can help to diagnose whether this patient is having malignancy or diagnostic clue in the management of pleural effusion. The second image in the lower part, you can see the CT chest where we will see that the split pleura sign is there in the right lung. So it may help to predict the patient is having empyema or not. It can always give the clue about the trap lung. So let's throw some light on the Light's criteria. We all know the Light's criteria. This is not a new thing. So pleural fluid protein to serum protein ratio more than 0.5, pleural fluid LDH to serum protein ratio more than 0.6, or pleural fluid LDH more than 2/3 of the serum LDH upper normal level. So the sensitivity of the Light's criteria is 98%, where the specificity of the Light criteria is 80%. So is it always exudate based on the Light's criteria? So my answer is no, not always. So we should go beyond the Light's criteria. Light's criteria may misclassify some of the transudate as a exudate, what we call as a pseudo exudate, especially in the setting of the ongoing diuretics. So in this scenario, the albumin gradient is a critical tool to unmask this type of pseudo exudate. So serum to pleural fluid albumin ratio more than 1.2 will suggest that this fluid is transudate. The novel marker NT-proBNP, we generally do the serum NT-proBNP, but yeah, we can definitely do the pleural fluid NT-proBNP. The level more than 1500 will suggest the fluid is transudative. Another level is cholesterol. Pleural fluid cholesterol more than 45 suggests the fluid is exudate. Pleural fluid to serum cholesterol ratio more than 0.3 will suggest the fluid is of the exudate. So there are routine lab analysis. So there is some standard panel that we usually send for the all pleural fluid, in all the patient of the pleural fluid, total count with differential count, biochemistry like glucose, protein, LDH, pH, microbiological analysis like AFP smear, culture, gram stain, KOH, AFP culture, cytology and ADA. These are the routine investigation, and there are some few specific tests that which we should send in our pre-test probabilities. Like if you are suspecting tuberculosis, send the fluid for the gene expert MTB as well. If you are suspecting any abdominal pathologies like pancreatitis related effusion, always send the amylase, pleural fluid cholesterol and triglyceride. In case of chylothorax, pseudocylothorax, anti-proBNP for cardiac related pleural effusion, or pleural fluid RF factor in case of rheumatoid pleurisy. So first define the pattern, whether the fluid is exudative or transudative, whether it is a neutrophilic or lymphocytic, whether the ADA is high or low, whether the patient the pleural fluid cytology is positive or negative for the malignant cell. So this is a very basic approach to define the pattern of the pleural fluid. Now we'll talk about the ADA. ADA is adenosine D- level. We all know, we will send, and there is a valuable screening tool. Level more than 40 is suggesting of the high likelihood of TB, while the level more than 70 is suggestive of strong suspicion of TB. But still, ADA is not a gold standard test that we should keep in mind, because there are chances in case where we get the high false positive reports in ADA, like in empyema, pneumonic effusion, lymphoma, mesothelioma, and rheumatoid pleurisy, where we will get the false positive ADA. So never ever start the empirical ATT just solely based on the ADA. So this is very this sentence we should always keep in mind, that never ever start empirical ATT. ADA is not a marker to start the AKT. Let's go with few cases. The case 1, 65-year-old male smoker. In the chest X-ray, you can see there is a right side of patient had dry coughing last 2 months with weight loss. So we did the thoracentesis, and the pleural fluid analysis was showing the fluid is exudative. Lymphocytes are 85, so it's a lymphocytic. ADA is 48, so it's borderline elevated. And we did the cytology, it's negative in the 2 sample. So the question is what to do next. Is it TB? Is it malignancy? So we did the CT thorax. You can see the first image. There was right side moderate pleural effusion. There was no definitive mass lesion, but you can see the irregular pleura, or round pleural. I have shown in the arrow that a few pleural nodules are seen in the CT. So next best option, either we can repeat the cytology, but it's already negative in the two samples. So either we can go for the CT guided pleural biopsy, or we can definitely directly go with the medical thoracoscopy, which is a gold standard. So we went with the medical thoracoscopy and pleural biopsy. You can see the second image. There are multiple pleural nodules, and we've taken the biopsy, and it came as a malignancy. So always remember, medical thoracoscopy in those cases for the tissue diagnosis is almost helpful. So in this suspected malignant pleural effusion cases, always first step and send it for the cytology. If it is negative, but still your clinical suspicion is high for the malignancy, either you repeat the cytology up to 3 times, or go with the CT guided pleural effusion, CT guided pleural biopsy. If still the persistent uncertainty or CT guided biopsy is not amenable, directly go with the medical thoracoscopy. Next, we'll go with the second case. 62-year female. You can see the chest X-ray, had a right side moderate pleural effusion. The patient was diabetic, right side mild to moderate effusion. I have presented with the high grade fever, chest pain, productive cough since last 10 days. And you can see it was a frank pus. Analysis was showing the exudative effusion, neutrophilic, 90% neutrophil. AD was very high, 80. Glucose was 45. pH is 7.21. And LDH is very high, 980. So next question, shall we continue with the IV antibiotic, or escalate the IV antibiotic, or put the chest tube? So the best option in case of the pus and empyema is never wait for pleural fluid reports. insert the chest tube as soon as possible, as early as possible, along with the higher IV antibiotics. So early drainage will prevent the fibrothorax, which will require the which will require the surgical option for the patient in future. So there is a dictum you can see: don't let the sun set on the undrained empyema. તમારા પેશન્ટને એમ્પાયમાં આવે તો સાંજ નહીં પડવા દેવાની આઈસીડી મૂકવા માટે, બરાબર. સો લેટ્સ મૂવ ટુવાર્ડ્સ ધ નેક્સ્ટ કેસ. This is an interesting one. 54-year male, alcoholic, smoker, coming from the rural Rajkot. You can see the chest X-ray. Patient had a right side very mild pleural effusion along with the right-sided calcified pleural lesions. Presented with the fever, weight loss since last 2 months. He had a history of old pulmonary coughs before 2 years, and he was a treatment defaulter at that time. Now he was started on the empirical ATT from some general practitioner, and but after no improvement, 2 months, he was referred to us for the further management. We did the diagnostic thoracocentesis under the USG guidance, and the pleural fluid was exudative, lymphocytic. AD was 82, very high. Cytology is negative. So, what should we do now? Patient already taking the AKT since last 2 months. No improvement. You can see the chest X-ray. He had a treatment defaulter pulmonary coughs patient. So whether shall we continue the ATT or shall we dig more deeper? So we send the gene expert. You can see the report. Pleural fluid gene expert was showing the MTB detected along with the rifampicin resistant detected. So thankfully our DTC Rajkot is doing very well in management of DRTB cases. So we sent the patient to the hospital and started on the appropriate DRTB regimen. Thankfully, he is still doing well. Pleural fluid gene expert sensitivity, although low, it's 60%. But never ever, forget to send the pleural fluid gene expert in TB endemic regions like India. Okay, so maybe you end up with the DRTB pleural fluid report once in a while. So now talk about the few confusing terms in the pleural effusion management. Bilateral pleural effusion, shall we tap? Is it always transudate? So mostly it is transudate, but not always. Most common causes we all know: the heart failure, renal failure, cirrhosis. But it can be exudative in case of tuberculosis, malignancy, pulmonary embolism, CTD, or some drug-induced pleural effusion. So when should we tap in case of bilateral pleural effusion? So you can see the chest X-ray and the CT chest image. When there is asymmetry in the pleural effusion, when there is one side dominant effusion in case of bilateral effusion, when there is poorly responsive to diuretic, and when in bilateral pleural effusion, patient had a fever or pleuritic chest pain or any systemic signs of infection, and if imaging is showing the pleural nodularity, so these are the scenario where we should tap. So this is also a confusing term whether we should do the therapeutic pleural fluid tapping or we should put the chest drain. So these are the indication of the therapeutic tapping. Whether the fluid is free flowing on the USG, if it is not a pus, if we need the temporary palliation in the malignant effusion, or if we need a symptomatic relief in the large transudate effusion. When should we put the chest drain? I talk like that is when patient had empyema, frank pus, complicated pneumonic effusion, when the fluid is loculated, septated, if it is rapidly reaccumulating, or if it is a chylothorax, pseudocylothorax, hemothorax, or malignant effusion when we are planning for the pleurodesis. So these are the cases where we should not wait, or we should always put the chest drain. Medical thoracoscopy. I can't talk more about in a single slide. Maybe Neeraj Bhai will talk more about the thoracoscopy and the pleura in the next session. It's a gold standard test for the whole undiagnostic exudative pleural effusion. The yield is 95%. Tissue is no longer an issue here in the thoracoscopy because we can get the enough tissue sample for diagnosis and the IHC or molecular marker study in the suspected malignant effusion. So your medical oncologist friend is always happy with this procedure. So the clinical clue is if your fluid cytology is negative, the clinical suspicion is very high for the malignancy, go straight forward with the medical thoracoscopy and the pleural biopsy. So another entity is a recurrent malignant pleural effusion. So we should shift our concept. In this era, we should shift the concept from just removing the fluid and from repeated thoracocentesis to improve the quality of life. Apart from the repeated thoracocentesis, there are two more options: talc pleurodesis and indwelling pleural catheter. We know the talc pleurodesis via chest tube we insert as a slurry or as a powderage. We can insert via the thoracoscope. there is 70 to 80% success rate. Indwelling pleural catheter, the EMPL trial done in 2017 had concluded that IPG reduced the hospital stay as compared to the pleurodesis. It's a home-based pleural fluid drainage, ideal for the trapped lung where pleurodesis is contraindicated in the frail patient in the advanced malignancy, when it is often placed for the long-term and the palliation purpose. So, another advancement in the intrapleural fibrinolytic therapy, we all know about the intrapleural streptokinase, or we may have inserted once in a while. But what is the latest advancement in this treatment is tissue plasminogen activator plus DNase to be inserted via the chest drain. Recently conducted MIST-2 trial in the December 25. They published a paper in Chest 25. It is concluded that it reduces the need of surgery and the hospital stay as compared to the conventional STK. The dose of this novel therapy, LT plus 10 mg plus Dornes 5 mg twice daily for 3 days to be inserted by the chest drain. It is highly effective in treatment of the local effusion, complicated peraneumonic effusion, and empyema. So, when should we call our thoracic surgery friends? Surgical approach in effusion, they do the VATS and decortication or may sometime open thoracotomy. So, indications are when our conservative measures fail, when there is a failure of the fibrinolytic therapy to drain the loculated or complicated effusions, when there is extensive loculation or multiple loculation not accessible via chest drain, and when there is a chronic fibrothorax that require the decortication of the thick pleural peel. These are the indication when we should directly refer the patient to the thoracic surgery. So, that's all from my side. This is the take home message. Ensure the routine use of USG in the management of pleural fluid. Lights criteria is not a definitive for diagnosing the exudative effusion. Go beyond the lights criteria. High ADA does not always mean that patient is having TB. Negative cytology does not mean that patient don't have any malignancy. Always upfront the gene expert testing in the TB endemic region. Thoracoscopy is still underused for the pleural pathologies, and consider the use of IPC and pleurodesis for the malignant effusion, and always think in clinical probabilities. Okay, just go beyond the lab reports and pleural fluid reports. Okay, so thank you for being there.